If you or someone you love takes a medication for an overactive bladder, oxybutynin, tolterodine, or solifenacin, I need you to watch this carefully. These are among the most commonly prescribed drugs for adults over 65. Many people have taken them for years, and in most cases, no one ever sat down and said, "Here is what this drug may be doing to your brain over time." A study published in BMJ Medicine, one of the most respected medical journals in the world, analyzed nearly 1 million patients. Their finding? Oxybutynin was associated with a 31% higher risk of dementia in older adults with prolonged use. And the American Geriatrics Society now formally recommends reducing or avoiding these medications in adults over 65, specifically to protect cognitive health. The good news is that a safer alternative already exists. It's already approved, it works just as well for the bladder, and most patients have never been told to ask for it. That is what we are going to cover today. This bottle right here. Most people see this and think under control, managed. The doctor prescribed it, it works, I've been taking it for years, there's nothing to reconsider. I look at it and I see something different. I see a medication that tens of millions of older adults are taking every single day, and that 3 large independent studies from 3 different countries have now linked to a significantly higher risk of dementia. I'm James Reyes. I'm not a physician, I'm an independent health researcher, and I've been reading the medical literature on medication safety in older adults for a long time. Nothing I'm about to show you is medical advice. What it is evidence that your last appointment may not have covered. And in my experience, that gap matters. Drop a comment right now with just your age, nothing else. I want to see who's watching, because what I'm about to show you depends on exactly where you are in this. Here is the situation. Overactive bladder, the condition these medications treat, affects somewhere around 30% of adults over 65 in the United States, 42 million people total. Many of them were prescribed one of 3 drugs, oxybutynin, tolterodine, or solifenacin. And many of them, most of them, have been taking those drugs for months or years, refilling the prescription routinely without anyone ever raising a specific question about what those drugs might be doing to the brain over time. That's not an indictment of their doctors. I want to be very clear about that, because I've been in enough hospital waiting rooms to understand what physicians are working with. A 15-minute Medicare appointment doesn't leave room for every conversation. Something gets prioritized and something gets deferred. What gets deferred in this case is the question nobody thought to ask. Not because the research didn't exist, but because the research arrived too recently, spread too slowly, and hasn't reached the average prescribing conversation yet. My father spent years in that system. Multiple strokes, multiple doctors, multiple prescriptions, each one written by someone who was looking at their piece of the picture. Nobody was looking at the picture as a whole. I started reading the research to understand what was happening to him, not because I had a medical degree. I don't. Because someone I loved needed this information and nobody was giving it to him in time. A woman who used to drive herself to every appointment, organized her own pills, made every follow-up on time, started forgetting the appointments altogether. Her daughter assumed stress. Nobody looked at the oxybutynin she had been taking for 3 years. That's the pattern, a slow drift attributed to age, to stress, because nobody connected it to the bottle on the bathroom counter. And here's what I found when it came to this particular class of drugs, the anticholinergics used for overactive bladder. These medications work by blocking a chemical called acetylcholine. Acetylcholine is what your bladder muscle uses to contract involuntarily. Block it in the peripheral nervous system, in the bladder, and the symptoms improve. That's the mechanism. That's why the drugs work. The problem is that acetylcholine is also one of the most critical neurotransmitters in the brain. It plays a central role in memory formation, in attention, in cognitive processing. and some of these medications, particularly the older ones, cross the blood-brain barrier. When they do, they're not just blocking acetylcholine in the bladder, they're blocking it in the brain as well. In my view, this is the conversation that should have been happening for a decade, and in most cases it hasn't been. Not because doctors don't care, because the research wasn't loud enough long enough ago. That's changing, and this video is about what the research now says and what you can do with it at your next appointment. How long has the person you love or you been taking a medication for overactive bladder? And in all that time, has anyone ever mentioned the word acetylcholine? The research on this is more specific than most people realize, and when you see the numbers and where they come from, you'll understand why this conversation keeps getting delayed. That's where we're going next. 3 weeks ago, I was sitting with this paper again, the one I want to walk you through right now, and I kept coming back to one number. Not because it's the largest I've ever seen in this literature, because of where it came from. The study was published in BMJ Medicine, one of the most respected peer-reviewed medical journals in the world, in November 2024. The researchers based in the United Kingdom built what's called a nested case control study. They identified 170,722 patients who had received a diagnosis of dementia. Then they matched each of those patients with approximately 5 controls, adults of similar age, similar background, similar health profile, who had not developed dementia. More than 800,000 people total across the entire data set. Then they looked backward. For each person in the study, dementia case and control alike, they tracked every prescription that had been filled in the years before the study window, and they asked, did these people take anticholinergic drugs for overactive bladder? For how long? At what dose? Here's what they found. Adults who had used oxybutynin, the most commonly prescribed anticholinergic for overactive bladder, with prolonged exposure, showed an adjusted odds ratio of 1.31 for dementia. That means a 31% higher association with dementia compared to adults who had not taken the drug. Solifenacin, 18 to 29% higher, depending on cumulative dose. Tolterodine, 25 to 27% higher. And this is the part that changes how you read that number. The risk was not uniform across all medications in this category. It was specific to the anticholinergic class, not to all bladder medications. Mirabegron, a newer drug that works through a completely different mechanism called beta-3 adrenergic agonism, showed no significant association with dementia risk in this dataset. Same condition, same symptom management, fundamentally different risk profile for the brain. Now, and I want to say this carefully because precision matters here, this is an observational study. It shows association, not causation. The researchers found that people who took these drugs were more likely to develop dementia. That doesn't prove the drugs caused the dementia. There could be confounding factors, underlying conditions, other medications, lifestyle variables that the study couldn't fully control for. But here is where the weight of evidence becomes important, because this isn't one study. The LIFE study, published in the International Journal of Geriatric Psychiatry in January 2025, followed 1.5 million older patients in Japan and reached the same conclusion. Anticholinergic bladder medications were associated with elevated dementia risk. Beta-3 agonists were not. A Danish nationwide study published the same year, 1.29 million participants, using an active comparator design, found the same pattern. Anticholinergics for overactive bladder, elevated dementia association, beta-3 agonists, not elevated. And here's what makes this convergence particularly meaningful. These studies used different methodology in different healthcare systems. nested case control in the UK, prospective cohort in Japan, active comparator design in Denmark, directly comparing anticholinergics against beta-3 agonists in the same patient population. When studies with structurally different designs reach the same directional conclusion, that is a signal that survived attempts to disprove it. One additional finding worth noting: the risk was higher in men than women. Adjusted odds ratios of 1.22 versus 1.16, and short-term use, fewer than 4 weeks, showed a weaker association than prolonged exposure. The risk builds with time. 3 countries, 3 independent research groups, 3 data sets totaling more than 3 million people, and they're all pointing in the same direction. That convergence, that's the signal. Has this come up for you or for someone close to you? Drop it in the comments. I read every one. If 3 large independent studies from 3 different countries all found the same pattern, at what point does association become something your doctor needs to discuss with you before the next refill? Before I get to the part that changes everything, the part that most videos on this topic get completely wrong, I need you to hold what you just heard. Here's what most coverage of this topic does. It reports the risk number. It says, talk to your doctor, and it stops there. That framing is, and let me choose this word carefully, incomplete. Because the risk number by itself, without what comes next, leaves people with 2 bad options. Keep taking a drug that may be affecting their brain, or stop taking it without medical supervision. Neither of those is the right answer, and neither of those is what the evidence actually supports. Write this down. The American Geriatrics Society's 2023 Beers criteria, the most widely referenced clinical guideline for medication safety in older adults, formally recommends reducing or avoiding anticholinergic medications in adults 65 and older. The specific rationale listed: preventing cognitive impairment, delirium, and falls. This isn't a fringe position. This isn't a preliminary finding from a small trial. This is the American Geriatrics Society, the professional body for physicians who specialize in the care of older adults, saying in their formal clinical guidance, be careful with these drugs, consider alternatives. Now, here's the counterintuitive, the part that gets lost in almost every conversation about this. The myth is there's a trade-off. You either manage your bladder condition or you protect your brain. Pick one. That's not what the evidence shows. Mirabegron, sold under the brand name Mirabegron, and vibegron, sold as Gemtesa, are both beta-3 adrenergic agonists. They improve overactive bladder symptoms through a mechanism that has nothing to do with acetylcholine.
They don't cross the blood-brain barrier the way the older anticholinergic drugs do. They're not blocking the neurotransmitter that your memory depends on. And the clinical evidence on their effectiveness? A systematic review of randomized trials found Mirabegron to be similarly effective as anticholinergic medications for reducing urgency, frequency, and incontinence episodes in overactive bladder. You don't have to choose between managing the condition and protecting cognition. The alternative exists. Think of it this way. The anticholinergic drugs work like a broad signal jammer, blocking acetylcholine everywhere the molecule reaches, including the brain, if it crosses the blood-brain barrier. Oxybutynin crosses easily. The brain uses acetylcholine for memory consolidation the same way the bladder uses it for muscle contraction. Block the signal in both places for years, and you may be managing one problem while quietly worsening another. The beta-3 agonists work on a completely different receptor, one not present in meaningful quantities in the brain. Different mechanism, different cognitive exposure. That mechanistic distinction is exactly why the AGS recommendation carries the weight it does. There was a clinical trial, the PILLAR study, a Phase 4 randomized controlled trial that looked specifically at the cognitive effects of Mirabegron in older adults with overactive bladder. Compared to placebo, using the Montreal Cognitive Assessment, a validated tool for detecting cognitive impairment, as the primary measure. Result? No adverse cognitive impact from Mirabegron compared to placebo over 12 weeks. That's, and I want to make sure I say this right, that's not a guarantee of long-term cognitive safety. The Pillar trial was 12 weeks. We don't have the same multi-decade data set for these newer drugs that we have for the older anticholinergics. What we have is no signal of cognitive harm detected at the population scale of the studies available, in contrast to the consistent signal detected for the older class. The bar for the beta-3 agonists is not proven definitively safe for all time. The bar is significantly better cognitive risk profile than the alternative based on current evidence.
And by that measure, the evidence is clear. Now, here's what I keep coming back to, and this connects directly to why this conversation hasn't been happening. Oxybutynin, in its generic form, is cheap, widely available, covered by virtually every insurance plan. Mirabegron and vibegron are newer. They may cost more without coverage. And until the evidence base built to the size it has now, 3 countries, multiple millions of participants, a formal recommendation from the AGS, there wasn't a clinical pressure point for prescribers to initiate the switch without patient request. You didn't know to ask, so in most cases, it didn't happen. A recommendation is not a verdict, but it is a starting point for a conversation. If a safer alternative with similar effectiveness already exists, what's the conversation you would need to have to find out if it's right for you? You now know something most people walking out of their doctor's office this week don't know. The question is what you do with it. Here's what I'd do. 3 steps, specific, concrete, and none of them require you to do anything before your next appointment with your doctor. Step 1. Review your current medication list and identify whether you are taking oxybutynin, tolterodine, or solifenacin, or any of their generic equivalents. Common brand names include Ditropen for oxybutynin, Detrol for tolterodine, and Vesicare for solifenacin. If you're not sure, call your pharmacy. They can tell you the drug class. That's their job, and they're good at it. Step 2. At your next appointment, primary care, urology, geriatrics, whoever manages your bladder treatment, ask one specific question. Write it down. The question is, I've been reading about the research on anticholinergic medications and dementia risk in older adults. Given my health history, would I be a candidate for switching to a beta-3 agonist like Mirabegron or vibegron instead? That's it. That's the whole question. You don't need to cite the studies. You don't need to bring the papers. You need to use the words beta-3 agonist and dementia risk in the same sentence, and your doctor will know exactly what conversation you're initiating.
Step 3, and I cannot emphasize this enough, do not stop any medication on your own without talking to your doctor first. Not oxybutynin, not any other prescription medication. Stopping abruptly can worsen symptoms, cause rebound effects, and create a gap in your management plan. The path forward is through your prescriber, not around them. A man in his mid-70s, 4 years on tolterodine, brought 3 words to his urologist last spring: beta-3 agonist. His doctor said he had been meaning to revisit the prescription and switched him to Mirabegron within 2 weeks. That conversation took less than 5 minutes. That's how fast this can move when you know what to say. The system isn't built to proactively review every prescription at every renewal for every patient. That's a structural gap, not a personal negligence. The volume of appointments, the pace of guidelines, the time pressure on every consultation, it's a math problem, not a care problem. But you can close that gap, not by fighting the system, by walking into the room with one more piece of information than you walked in with before. You are not a passive recipient of medical decisions. You are an informed participant in your own health. And that distinction between someone who walks into an appointment not knowing what questions to ask and someone who walks in knowing exactly what to ask, that distinction changes the outcome of the appointment. Now, let me be precise about what we've covered, because I want you to walk away with this clearly. The evidence from 3 large, independent studies totaling more than 3 million participants across 3 countries shows a consistent association between anticholinergic medications for overactive bladder and elevated dementia risk in older adults. The association is not proof of causation, but it is strong enough that the American Geriatrics Society has formally recommended reducing or avoiding this class of drugs in adults over 65. That is a clinical guideline, not a warning label. It has weight.
The alternative, beta-3 agonists like Mirabegron and vibegron, has demonstrated similar effectiveness for bladder symptom control with no significant association with dementia risk detected across the large datasets currently available, and no adverse cognitive impact in the PILLAR randomized controlled trial. Nothing I've said here is medical advice. What it is the research your prescriber may not have had time to review this week. Your job is to bring it into the room. If you're walking away from this video differently than you walked in, drop "informed" in the comments. If this is the kind of research you want to keep seeing, evidence-based, specific, without the sensationalism, the subscribe button is right there. I don't post every day. When I post, it matters. And share this with someone who needs to hear it, because most people who are taking these drugs right now don't know this conversation exists. What's the one question about your own medication list that you've never asked because you didn't know you were allowed to? There's one more layer to this that I didn't cover today, and it changes how you interpret everything I just showed you. It's about the cumulative anticholinergic burden, the total anticholinergic load from all your prescriptions combined, not just the bladder drug. Most people taking one anticholinergic are also taking others from different drug classes for different conditions, and the risk compounds. That's the next video. Don't miss it.